Hello. Hello. Hello.
Good evening, doctors.
I was checking my audio.
Yeah,
Am I clearly audible?
yeah, you are audible, doctor.
Okay. Thank you. Thank you. Hello, Dr. Panigrahi.
Hello. Hi. Jyote, namaskar. Unmute, unmute. Nalini. Hello, Nalini.
Hi, good evening. Good evening to all.
Good evening. Kemte acha? How are you?
ठीक ठाक चलती. Hi, Dr. Radhika. How are you?
Hello, hello. How are you? Good evening.
Good evening, Dr. Panigrahi.
Namaskar. Good evening.
Good evening, madam.
Good evening. Good evening.
So we all are ready to go. Probably another 2 minutes. So I hope this session is now live stream only.
Yes, doctor, we can start at 8:05 probably. We'll stay for 5 minutes more.
Okay.
Oh, perfectly fine. So do we know how the Sweta there, na? So how
Yes, sir.
can you know that the attendees, anybody joining there? Because we are panelists actually.
No, that will be, the report will be shared by our technical team in few days.
No, if there are any questions, then
Yes, there will be questions in that case, and I'll post them in this chat box. Then we can answer that question.
yeah. So maybe you can post it in the and the participants link, that questions can be posted.
Yes.
So, is shown any of the Nnf office bearers, do they receive any of the link to give to the audience, the attendees there? Or
I am Dr. Mongol from NSWB. Yes, I am Dr. Mongol from NSWB President, Neonatal Society, West Bengal.
I was asking actually how the attendees are joining, how any delegate link available from the DIP?
I can't understand. Please repeat again.
No, any link actually, delegates links available from, because this link we joined from the panel link, but how the delegates or the attendees they are joining, from which link?
You have sent that link and I have opened through this link. Directly I opened this link.
Good evening, sir.
Good evening,
sir. Good evening, Dr. Anup, sir.
Yes, sir. Thank you.
Yeah.
This DIP people are time and again muting us. Nalini, how is the flow of the things?
The flow actually, normally there is a small introduction of 1 or 2 minutes, then we will go for a brief recorded version of the presentation by Dr. Naveen Jain sir. So that's probably will continue.
Okay. So here welcome our treasurers of Central Nnf, Dr. Surinder Singh Best.
Yes, Surinder Singh.
Thank you.
Surinder Singh, how are you, Surinder Singh?
I'm fine, sir. Thank you.
Namaste, sir.
Namaskar, sir.
Namaste.
Hi, Dr. Surinder Singh.
Hi, sir. Dr. Radhika is there. Okay. Dr. Anup.
Hello. How are you, sir?
Hi. Dr. Panigrahi, Dr. Rijit. It's like meeting again after such a. अभी तो मैंने तो 2 दिन पहले Dr. Rijit.
We are meeting every day. Probably we are meeting.
ऐसे ही होना चाहिए. दोस्तों को बार-बार मिलना चाहिए.
Right.
So.
So Naveen will be joining.
He said he will be a little bit delayed because he is outside somewhere. He asked us not to wait and to go ahead with the program.
Okay. Then I think Nalini, you can take the lead and start.
Yes.
So, Sweta, are we live here or just we have the panels open only?
I think we are live.
We are live. You can check on the viewers link.
But we don't have the viewers link actually.
These links are there.
I mean, you need two separate devices then.
Okay.
So I think we can start. So we can do the.
We're live. Are you live?
Yes, doctor, we are live. I'll be
Okay.
posting this viewers link here also in the chat box. You can also check
Okay.
the comments
Okay.
there.
Okay.
So, good evening, everyone. Here in the session of Detect program in the East Zone, Nnf East Zone, I welcome all the office bearers of Central Nnf. Dr. Singh is available and Dr. Jyoti Prakash, Dr. Jyoti Prakash sir and Dr. Anup sir. But I wanted to expect some of the office bearers from Assam also. Nnf office bearers and secretary.
Yeah, Assam, Rajesh should also join. I don't know where he is.
From Ranchi and from
Ranchi.
Assam.
Then Bihar is also there.
It's already it is 8 o'clock, so another 1 or 2 minutes I can wait for.
Okay, doesn't matter. ज्ञान बढ़ रहा है, जो लेगा उसको अच्छा रहेगा.
That's good. Yes. We are live now since DIP is already streaming the program. So,
Okay.
Dr. Nalin.
I rename here. But Naveen still not joined.
Dr. Rijit, since you are the EB member from this who is present, can you just get Rajesh on board or some other people from Assam on board? Do you have the?
Okay, I'll just give a call, but as I've joined from the mobile, it may get caught. I'm calling Rajesh.
Okay, thank you.
So as it is a recorded session, we can wait for 1 or 2 minutes. With people joining, then we can go ahead actually. So not be issue.
Sure.
Doctor, we can start, right?
Waiting for 1 or 2 minutes, then we can start actually.
Okay. Okay.
Dr. Anup, since this time, I have already given you one company's number. from some ventilator company. I think one more Massimo or some that I'll give you again. And
Okay.
I did talk to them about that.
What about the Durgapur Mission Hospital?
We'll talk that. We'll talk about that.
Okay.
Dr. Naveen, hi.
Thank you. I'm sorry I'm late. I was just traveling from somewhere. So thank you for waiting, and I hope we are ready for starting the program.
Yeah, just waiting for you.
Sir, we are ready. We're just waiting one or two person join from West Assam and Bihar Nnf. Probably it is 8:05 for us. We can start now, sir.
With your all permission, I will join briefly because I have some guests at home. And after that, I'll just after the startup program, probably Dr. Nalnikant and Dr. Radhika will continue the discussions.
Good evening, sir. Naveen sir, good evening.
Good evening to you. Good evening. कैसे हैं?
अच्छे हैं. Sir, this is a very good program, sir. This is a very good initiative, and all the I mean, I compliment you for your effort.
It's been a very good effort from NNF itself to try and take developmental medicine to through the program, and I have good help from all my colleagues, Dr. MKC Nair sir, who is my teacher, and Dr. Nalnikant, Dr. Radhika, and Dr. Reba.
Dr. Reba has joined, I think.
She said she will try to join in, but she had a small child to take care of at home, so I'm not sure that she's able to join in time.
Okay.
I think Dr. Arijit has already made his attempts. And Dr. Rajesh must have been.
Yeah, Rajesh, I spoke to Rajesh. He's in another meeting. He'll be joining after some time. So we can start.
I will request Naveen sir to start initial little introduction.
No, dear Nalini, you take over. I am just there. Please take over.
So good evening all for the program of the Detect. This program is conceived by Nnf India, and under the presidency of Dr. Ranjan Pejawar sir, he visioned this idea of developmental screening program, and this proposed by and completely the Nnf Detect program, which is the developmental deviation detection in office practice by the pediatrician, and how early to refer. The idea, as we know, the doyen of the developmental pediatrics in India, Dr. MKC Nair sir, guided and with the experience and knowledge of last probably 15 years, whatever developmental pediatrician Dr. Naveen Jain sir has practiced and contributed, he in the very briefly to the pediatricians in the office practice, how we can guide to the pediatricians with what simple tools they can identify the deviations in the normal or at-risk babies who normally we expect the normal development with the minor deviations. How to
detect wala program hai.
Yeah. So how to detect the deviation and how early to refer the right treatment. Probably this will be discussed in the first 0 to 6 months and the 6 to 12 months in 2 different presentations and 30 to 40 minutes presentation each one. 2 presentations will be live here, the recorded session. In between, we can take the questions and discuss. Dr. Radhika, me, and all the panelists, we can discuss further what best way we can do this detection of the deviation, developmental delays in the local the office practice. So I will request any of the office bearers of NNF from Bihar, Odisha, West Bengal to speak a few words. Then we can go for directly the live session. I will request.
So, Dr. Nalin, on behalf of LNF India, let me first propose a vote of thanks initially also to Dr. Naveen Jain and your team who have been so instrumental and so important in carving out this very important program, which has been appreciated and you can say accepted so well in all parts of country. In fact, there is demand from other countries as well to have this program there. So this was echoed in our last EB meeting. The Secretary NNF so full-heartedly praised the efforts of the team, and it was appreciated. And I think with people thumped the tables for such a good program in the EB meeting as well. So congratulations to you all. And East Zone. And I'm so happy the East Zone EB members, Dr. Arijit and Dr. Rajesh are here. And we have seen in other programs as well as in quality improvement, all that. East Zone participates full-heartedly. And their members work very hard. And we look forward to very good participation today itself. And we hope this will be a beginning of a very successful conference in December in Kolkata, which will be hosted by kind of East Zone only. And I think we are going to have a East Zone zonal conference in Ranchi as well in under Dr. Rajesh sir. I think you are the host for a zonal NNF conference in Ranchi, and we hope that all this bonhomie continues in both the conferences we see in the East zones. Thank you, sir. And please, there are EB members and from East Zone, Dr. Arijit and Dr. Rajesh. And then I'll ask the state office bearers to please just say a few words.
Thank you, Dr. Surinder, President of National NNFI, for the kind words and support. And let's other the main members, any words, few words to start, then we can start rolling the program later. Shortly. So, Dr. Arjit sir or Dr. Rajesh sir, few words about the.
Yeah, this is good evening, everyone. So, good evening, Dr. Beast from Central NNF, Dr. Naveen Jain, Dr. Jyoti Prakash Mishra, President Odisha, Dr. Anup Mangal, President West Bengal Neonatal Society, Dr. Rajesh Kumar, Secretary NNF and IAP both. Jharkhand and East Zone representative in Central NNF. So this has been an excellent program over the year, which has been conceived under the presidency of Dr. Ranjan Pejawar. And this is a very important program which impacts all the pediatricians in their daily office practice. So, and it has been very elaborately and simplified manner the knowledge has been being distributed. So I'm really so happy that today also many of our East Zone members, whoever sees it, will be benefited by this. So please, over to Dr. Rajesh.
Good evening, everyone. Hello, Naveen and Arjit and Beast. And this program we had done in Bihar, Jharkhand, I think hardly 2 months back. And it has been mentored or designed by Naveen. And as usual, he makes the things very simple and clear. This program also, like webinar, is very, very simple and easy to understand, and minimum what you require for following up our NICU babies. I think it will be helpful for the East Zone members. Thank you. Thank you. Naveen, you can start.
Thank you all. Nalini, we will start the program.
Shall we proceed, Sweeta? Just as we can start the recording. Then in the meantime, we can take the questions and discussion further.
I request all to kindly mute yourselves in between.
Every parent wishes that their child be normal, play like other children, and perform the best in their life. As pediatricians, we have the opportunity and responsibility to ensure that every child can achieve his full potential. We often meet parents who are disappointed that their child has a developmental problem. We have found the subject complex and therefore often wait and refer very late. In this program, we will discuss in 2 modules of 40 minutes each. The first one for babies from 0 to 6 months and the second one from 6 months to 12 months on how to detect early and refer the babies for appropriate treatment if we suspect a developmental delay. Parents every day wake up expecting the child has learned something new, has started smiling, has started interacting with them, sitting and standing, and saying complex new words. If they discover that their things are not moving normal, or if the pediatrician tells them that there is a problem, they go through the same cycle of denial, anger, and complete depression. The question they ask is, "Doctor, could you not have detected earlier?" Please remember, what we are trying to detect is an infant who is different from most normal babies and not abnormal. The word abnormal should never be used in developmental medicine. The question most often pediatricians have asked us in programs that we conduct or workshops that we conduct for developmental detection is, what next? What if I have picked up a baby with developmental delay? I do not know what to do, where to refer, and often parents and the pediatricians seem to be in a state of anguish as if there is no solution from here on. So in this program, we will take together both the science of detection and simple ways of how to treat these children and help them hand in hand, slide after slide. This great teacher of developmental medicine, Dr. Illingworth, stated that all developmental assessment should happen in the pediatric office, in the outpatient service, with no special room required and no special tools required. Although a specialist may say the child will get distracted, Dr. Illingworth said this is where he is going to perform and this is where he should be tested. The whole aim of this program is to sensitize pediatric colleagues, residents, and practicing doctors and teachers to pick up and treat these children in a simple way. It is by no means a comprehensive document. To completely learn the science of developmental medicine, we may have to refer to a complete textbook of developmental medicine like the Illingworth. Also remember the famous words Dr. Illingworth quoted. In development assessment, we can say something about the child's current state and potential. But what we cannot say is what he will do with it. So none of these items are meant to predict the outcomes of a children in terms of superior intelligence. Although it is the most obvious and the most easy to examine, the head growth is seldom measured in pediatric practice. It's possible that the extreme simplicity in measuring the head performance is the reason why it doesn't get tested. Often an MRI would happen before head circumference is serially measured. Although head circumference may not completely reflect the brain growth, but it is obvious if the brain is growing poorly, the head circumference would also be small. Head circumference should be measured with a non-stretchable tape placed on the forehead and the most prominent part of the occiput passing over both the ears. One must record the head circumference by himself and not delegate it to a nurse or a resident. Each pediatric visit in infancy must have a head circumference recorded and plotted on the growth chart. One must also record the length and the weight and compare the growth of the head in terms of especially the length of the baby. In this graph, you can see the head is also tracking along the centile line, as is the length. Whereas in this graph on my left, the baby's head is failing to grow effectively. The head seems to be static over the weeks. And on the right, you can see a fast growing head that might draw attention to a possible hydrocephalus. In both the cases, the length has been tracking on the line, and it's only the head that has failed to track the way it should. In children with developmental disorders, they may give us clues with risk factors that were already there, but sometimes there are no known risk factors at all. There is complete distress in both the families as well as the pediatrician in how to recognize early in those babies who have no risk factors. Can we pick them up early? That is the question. A serial growth record, especially that of the head, and developmental assessment done in the OP practice for apparently healthy children using a very simple tool would be the way forward. I would propose a 10-second rule. When the family walks into the OPD, straight away do not jump to the reason why they have come, a medical problem, a respiratory illness, a diarrhea. Just look at the child for 10 seconds and listen to what parents have to say, and the child has to act. Ask for the gestation and the birth weight of the baby. Go back to the antenatal risk factors, especially in early infancy, any neonatal problems that were there, and also check the hearing screen report, the thyroid reports, and if the baby is a deserving candidate for ROP screening. Risk factors may be prematurity, asphyxia, hypoglycemia, antenatal anomalies, severe neonatal jaundice, neonatal seizures, and many of them. Presence of a risk factor of this kind should allow you to flag the baby and follow up more carefully. Very often, when the parents are told that there is a risk factor, immediately they get worried. Doctor, is this serious? The question is, how serious or how severe is the risk factor? A very simple common sense approach would say a baby who required resuscitation at birth needs attention. If it was that he required chest compressions and medications, it is even more worrying. And a baby who at the end of 2 weeks of treatment of HIE still remains abnormal, requires tube feeds, gets seizures, is not playful like normal, is more likely to have problems. This kind of severity tag or stratification is going to help in deciding who requires a closer follow-up. We in our unit use a book called as the Blue Book for all these babies with risk factors. But if you do not have one, either you can write to us for a free copy of the Blue Book or simply generate a simple notebook. The notebook's presence in the family's hand will draw attention that this baby has risk factors for developmental delay. So what we learned so far is please measure the head circumference serially for all babies. Flag babies with a notebook if they have risk factors. Do not call them high risk, call them at risk. Calling them high risk will have the parents running away from the follow-up service. Stratify whether the baby is at higher risk or at mild risk for developmental problems, and follow them with a simple developmental tool called the developmental observation card. The whole session today is going to be dedicated to learning of this very simple tool called the DOC or the developmental observation card. Dr. M.K.C. Nair, the mentor of developmental medicine in India, evolved a very simplistic tool in which he said, please see at 2 months if the child has social smile, has head control at 4 months, sits independently at 8 months, and stands transiently at least at the age of 12 months. Remember to correct for prematurity. If the baby was born at 36 weeks, then you may allow 1 more month before you assess a developmental delay. So the baby should smile at 2 months, have a good head control at 4 months, sit independently at 8 months, and stand at least momentarily for 12 months. At each assessment visit, make sure the baby can see and hear. Further away that the child is from this expected milestone, more is the worry and more likely that the child is going to have problems. Let us first go to a 2-month assessment. At 2 months or 6 to 8 weeks vaccination visit, a social smile should be there. A delay is always a concern. Please look at the picture. Baby is looking very intently at the mother. A social smile involves the baby looking at the mother and smiling in response, in communication with the mother. A smile that the baby gives in dreams, in sleep, or randomly is not a social smile. So absence of social smile at 6 to 8 weeks is always a serious concern. There is no waiting and watching from here. The child may be showing the first signs of global developmental delay with something serious in the brain. Baby may be having hypothyroidism, and even if checked before at birth, it may be worthwhile to repeat the thyroid screen. We must also look for visual problems which may be preventing the child from smiling at the mother. Although red reflex must be done in the neonatal period, if not done before, one must perform the red reflex now. Please note, in red reflex, the ophthalmoscope is kept close to the examiner, to the pediatrician, and not close to the baby. Light is shown onto the eyes, and one looks for equal red responses from both the eyes. And asymmetry draws attention to a problem. What does an ophthalmologist look at if you refer the child to him? The baby may have nystagmus. This may be a sign of serious visual disorder, a clouding cornea, a abnormal red reflex, a cataract. And if an ROP screen is required, whether it has been completed, fundus examination in a term baby after dilatation, and look for refraction. In this picture, you can see a baby with HIE who was being managed, and this baby before that, he was unable to even sit properly and unable to walk. The mature babies, please remember to do complete If there is corneal clouding, keratoplasty can be done to allow light to go in. If the cataract is unilateral, it requires early surgery, and refractory problems like this one can be corrected. If the baby has no visual problem but still has delay in social smile, one would seriously think of a neurological disorder. Such a baby may show a good pupillar reaction, but no tracking to light and no fixation at all. Other markers for early neurological problems that may be that the child does not lift his head in sitting or prone position. You can see that when the baby who is less than 2 months old is made to sit up with a hand supporting the head, a normal baby would tend to lift the head a little bit, at least to the central point, and then there may be a wobble. But a baby with a developmental motor problem may not lift the head at all, like in the red box shown here. You can see this 2-month-old baby who is lying prone on the mother's shoulder. See how he constantly lifts the head.
Full head
This kind of head lift may be also seen in prone as well as in ventral suspension. In ventral suspension, the baby is held up from the couch with the hand supporting the lower part of the abdomen and chest. And you can see a healthy baby would lift his head and his hands and legs would flex. Whereas a baby with a motor disorder will have his head hanging with no effort made to lift at all. And as well, the hands and legs may hang loose. It is obvious to state that the baby should not be in deep sleep or on anticonvulsants or other sedatives when you perform this examination. A severe head lag like this also indicates a problem. When you try to lift the baby from the couch, normal baby would try to hold the baby head along the line of the body, at least transiently, even as young as 2 months of age. If the head lags completely with no effort to lift, this may be a bad sign. You can see in this picture the posture of a baby who lies normally with his hands and legs flexed and moving completely is a healthy baby. A baby who is lying completely immobile, hands and legs lying loose with hardly any movement is a concern. Also, like the picture on the right, a baby who is lying with arms completely flexed and not moving most of the time, and legs lying in complete extension may be signs of a serious neurological problem. Some other objective signs may suggest either motor or cognitive problems. One is the quantity and quality of movements. I will show you in the next video, as well as the alertness of the child to the surroundings. These are twins who we pictured with their parents' permission, and one baby had more medical problems than the other. Complete trying to move his hands and legs, whereas the baby on the left, one who was sicker in the ICU, has definitely less quantity of movements, as well as the variability and quality of movements is less. So good movements would be fluent, frequent, variable, and lack jerkiness or tremor. Other early and non-specific signs of a developmental problem may be constant and nagging feeding problems, a baby who has excessive crying that doesn't seem to settle down and brings the parents back to hospital frequently, problems with sleep which do not settle over the weeks, and sometimes a life-threatening event that causes the baby to be rushed to the hospital with choking, going blue, lying still may be signs of a developmental problem. So at 2 months or 6 to 8 weeks visit, the baby should have a good social smile, and a delay is always a concern. He should have some effort to keep his head along the trunk when he is lifted, and a serious and consistent head lag is a concern. Look for quantity and quality of movements. Now, what do I do if I find a concern? Do not immediately declare that the baby has a problem. Reassess after 2 weeks. A milestone that is not improving, that is called persistence of abnormal signs, is more likely to be abnormal. A neurological examination that is still abnormal after 2 weeks in the form of head lag or in ventral suspension, the limbs and the head hanging loose, and a head circumference that doesn't improve over 2 weeks is definitely a worry. Similarly, a baby who had severe asphyxia at birth, requiring chest compressions, and showing combination of signs like poor head growth and severe head lag is of a greater concern than a child who has severe asphyxia, but head growth grows normally, and also fortunately there is no head lag. This child may be better than the previous one. What should I do if I detect a baby with a neurological problem? Of course, I need to refer early to a pediatric neurologist. He may perform an MRI to pick up neurological abnormalities from birth or severity of HI. He may do metabolic tests and genetic tests. We will be discussing them in detail in the second presentation. They would also prepare a list of comorbidities. They may plan medications to reduce the tone, to decrease seizures, to improve sleeping problems, all of which we will discuss again in detail in presentation 2. They may send the child for early intervention to an occupational therapist. Now moving on to 4 months development. At 4 months, the child would have good head control. You can see the baby sitting up in the mother's hand would have a head in midline, which would not wobble. That's what being shown. So like in the picture on the right side, where the head tilt, the child would be having a well-controlled head. He would be alert to sound, alert to the picture shown to him, track objects, and have very good interaction with the examiner. So these 3 features would identify 4 months development. So at 4 months, the child should have good head control and should track objects well and turn to sound as well. In addition, at 4 months, the child makes an effort to roll over, and this would require that the ATNR, the asymmetric tonic neck reflex, and the Moro should disappear. ATNR should go away by 4 months. If the baby still shows the sign, then there is a problem. A Moro should be also absent by 4 months of age, and a persistent Moro is a definite indicator that the delay in motor milestone is due to a pathological reason. By this age of 4 months, the child keeps his hand open for most of the time. So a hand which is fisted, a hand which does not open up is a serious concern. At this age, you may label a baby as high risk of cerebral palsy. You may not use the word cerebral palsy by itself. So there will be a child who has delay in motor milestones, like having poor head control, not rolling over, persistence of primitive reflexes like the ATNR or Moro, poor hand use, hypertonia and hyperreflexia, a small head, and setting of risk factors like extreme prematurity or asphyxia to begin with. For hyperreflexia, when you elicit a knee jerk, it is abnormal not by the size of the jump of the leg, but on how far from the patellar tendon that you can elicit the knee jerk. So if you go to the shin and still get the knee jerk, it is not good. And if you can elicit even from the ankle, then definitely the knee jerk is abnormal. Hypertonia in the lower limbs would be shown by a tight adductor angle. You can see less than 60 degrees. Even crossing of legs may be seen. And hypertonia of the upper limb can be picked up by looking at the scarf sign. In the scarf sign, you hold the wrist of the baby and try to pull across to the opposite shoulder. What you're noting is how far the elbow would go. Normally, the elbow would cross the anterior axillary line on the same side and move into the body line, like here. So the elbow would lie somewhere between the two sides of the body. But a hypertonia of the upper limb would not allow the elbow to be pulled in and therefore would not cross the anterior axillary line. At 4 months, we told baby should be very keen, alert, and looking at an object. You can see the baby looking at the red ball. Also, he would be trying to reach out and track the object. You can see in this picture, the child is very alert, keen, and playing with me at 4 months of age. And when he is shown an object, a torch, which is not lit up here, just for the red color, you can see how keenly the child is trying to follow the object. So you don't need any special tools. At 4 months, when the child comes for vaccination visit, do look for a good head control and also whether the child can track to the height and if the child is not listening, then there is a concern, and even a baby who has passed the OE previously should undergo a BERA testing and be referred early for a hearing aid by 6 months of age. So a keen, alert baby who tries to catch an object, who sits requires the child to become track sounds, track light, and have a good head control. Absence of these should alert you to the possibility of visual problem, global development delay, or a once again, head steady, holds objects in hands with hands open and looks and turns around for objects. So what we have told so far, or summary of DETECT at 2 months, is the child should have a social smile. He should lift head with no lag at all when just tried to pull to sit. He should have good movements. And at 4 months of age, the child should track and turn to both light and sound. He should have a good head control, try to roll over, and have a good hand use. Besides brain factors, there could be medical reasons for developmental problems. One must do a hip examination at every visit in an infant. Currently, we do not recommend hip screening in newborn, and therefore it's very important to screen for hip dislocation on follow-up examination. Asymmetrical abduction, not able to completely abduct flexed hips, is a sign of a dislocation of hip, and you must refer to a pediatric orthopedic specialist. He may completely once again examine and confirm that by ortho-Lanin test he can't seem to put the hip back. X-ray will confirm the dislocation, and the child may require a harness to protect the hip from damage. There may be other problems like a meningomyelocele, need not be only with one glove. See the leg without a meningomyelocele, and the one having hardly any movements on the one with a spinal cord. These two together, but if we have not seen the normal twin, we don't train our eyes for normal, we may sometimes fail to be sure without an MRI whether the baby has Nnf Detect or not. So please remember, we need to take the medical and neurodevelopment care and assessment together. It might be looking very complex. We are asking you to do a risk stratification and listing, do an eye examination ROP check, plot the head growth, do a neurological examination, do immunization for all these babies. Is it possible? Will I forget? Will I miss? So a simple way to do this complex care is to have pre-printed leaflets or booklets. We have this in a book called Blue Book, which we're willing to share with anybody who mails to us. Thank you for your attention for the first session.
Does any question from DIP which you can take now or after the? Dr. Radhika, we should go for a small brief discussion here, or the later after the complete presentation we can initiate a discussion among all.
If anyway, we cannot see any of the chat box, any questions if they are there or not. No, so
it should be probably collected by Shweta to be redirected to us. But what we can do, we can start the next session.
Yeah, I think in the end we can discuss, and if from the experts, if there are any comments from the doctors, we can take that as well. So shall we proceed with the second?
Yeah, we should probably request Shweta to start the next session.
Sure.
Then after end of the session, we can go for a discussion involving all the panelists, and we can go for a few relevant point discussion.
Okay. Okay, we can go ahead then.
We would like to remind that this program is only meant to sensitize pediatricians to pick up developmental delay and refer early. This is by no means a comprehensive program. One may have to study a development book like the Illingworth to be able to pick up developmental delays comprehensively. Also that the aim is not to predict future outcomes, but only to find infants who may benefit by early referral and treatment. By 6 months, babies are extremely exciting and playful. They interact with the child, with the parent, with the pediatrician. They reach out for toys, grasp them, and transfer from hand to hand and to the mouth. And the mnemonic goes that by half year, they're able to say half words. They have babbling, social babbling. They're able to say something in their baby language. You will see in this video that the infant is able to reach out for the toy, which is a pen in this case, to take it to the mouth and to the other hand. You can see how playful, keen, and attentive the baby is to the object that is there. This is an important milestone for the infant to be able to reach out for the objects that are being offered to him. Not reaching out for the toy by 6 months of age should make one suspect that there is a problem either with vision or the child has a serious problem with his brain development, with milestones failing in more than one domain, what we call as global developmental delay. The problem may be one of early cerebral palsy, where both programming and execution of motor function may not happen. We may have an opportunity to look for asymmetry, and maybe a pointer to hemiplegic cerebral palsy or problems like Erb's palsy. As you saw in the video, the child was very alert, interested in everything around, responsive to the call of the mother, and concentrating on the objects he was trying to reach. These have been called as insurance factors. Presence of these wonderful interactive signs make us assured that the child does not have global developmental delay and his social development is good and unlikely that this child will have autism spectrum disorders. Now we get back to our CDC grades, the development observation card. The 8-month milestone is that the infant should be able to sit well for some time. You can see in the picture that we had at 2 months the requirement that the baby should smile. At 4 months, the infant was able to hold his head well, and by 8 months, he should be able to sit well. The picture on the right shows a cartoon and a picture of a baby who at 8 to 9 months can sit steadily with the back straight, can pivot around and look around. If the infant has to take support on his arms or tends to prop forward, this is not a mature form of development for an 8-month-old baby. When we put the baby in sitting position, if he tends to fall back periodically, repeatedly, tends to pull up his legs and knees because of hamstring spasm, they may suggest diplegic cerebral palsy. An infant who can sit with the back straight, head in control, and the legs easily spread out is a good baby. Not being able to sit may either be cerebral palsy or maybe a local neurological problem like that one of the hips or that of the spine. We will see these two videos on how infants are sitting at 10 months of age. Hi. In the first video, you can see that this young baby is sitting with back tending to get rounded, head tilted to one side, and he is wanting to play with the pen but is not independent. He tends to lean forwards, and the parent is worried that he might fall and tends to give support to him periodically. In contrast to the young child we saw in the previous video, you will find a child in age who is able to sit very confidently with a straight back, happily playing, see the free use of his hands, with a good head control. He is able to turn around, pivot, complete freedom. And there is no anxiety in the parent that the child may fall down. They're sure about his sitting. I'll show you the previous video once again. Hi. You can see this child who is also sitting up, but he tends to lean forward, head is tilted, back is rounded, and even though the child wants to use his hands and play well, the child is unable to do so. He's always tending to lean forward, and the parent is trying to hold him because they feel that he might fall over from their previous experiences. So, maturity of good sitting includes not just being able to sit. The child should sit with a straight back, good head control, be able to pivot around and play well with the hands. One must also observe that the head tilt by itself may be a sign that may indicate that the sitting is not mature. This mother brought this child to me because the child was keeping head tilted most of the time. One must also be reminded that single signs should not be used to make diagnosis of neurodevelopmental problems. If you carefully observe, this infant has a very good pincer grasp. He is able to hold head അങ്ങോട്ട് tilt ചെയ്യാൻ tendency ഉണ്ടോ എപ്പോഴും with her hand with thumb and fingers together, index fingers together, and able to even freely exchange the object to the other hand. This made me reassured that possibly the head tilt is an isolated sign and may not be an indicator of cerebral palsy. In fact, on follow-up, the child was all right on developmental. This picture I borrowed from the CDC milestones. You can see a mature pincer grasp. The infant is using his thumb and index finger to pick up a small object. This requires good hand-eye coordination and therefore is a effective test of his vision, his brain cognition to be able to reach this object, and motor coordination. So in one test, you can check all the three functions together. It is understandable that at 9 months, if you do not have a good pincer grasp, the problem may be due to refraction, cerebral palsy, or global developmental delay. By this age, a pediatrician may often forget to ask about prematurity, and an accidental age calculation can label the milestone wrongly. So do correct for prematurity before you say the child has developmental delay. Motor function requires good coordination both from the brain as well as the muscles. If there is cerebral palsy, the child cannot reach out to the target, he misses the target. In this case, a baby elephant placed on the table. Also has a splayed approach because of lack of coordinated movements of the hands, which require flexion and holding of the object. Splayed hand approach and missing the object is a definitive marker for cerebral palsy affecting the upper limb. We must also look out for asymmetry, which becomes more evident as the child gets older. In this picture, the child is reaching out for an object with the right hand, the knob of the door, the slippers on the floor, but is unable to use his left hand effectively. It is fisted in the hemiplegic posture. He can't draw the left leg also into a well-flexed position because of a spasm of muscles. This is diagnostic of hemiplegic cerebral palsy. By 9 months of age, we are also able to evaluate an important developmental milestone, that is social development. Children start waving tata and bye-bye. They would affectionately say mama and meaningfully, not just the sound. They would also start developing anxiety to strangers. They can differentiate self from other members. Joint attention means the ability for the baby to join the point of attention drawn by the mother. If she points the finger to the fan and says fan, the child looks up towards the fan and associates the word fan with the object shown by her mother. If this is not there, learning process will not happen and may be the first pointer for autism spectrum disorders. If a child does not have any back and forth play with the mother or lacks a joint attention completely, one must be concerned. Please remember, if both parents are busy at job and the child is confined to a mobile phone or a tablet game or a television, what we call as gadget overuse, and doesn't have opportunity to interact with human beings, they may develop symptoms similar to autism spectrum disorders. We just talked about the ability of the child to learn playing with the mother. You can see in this video that the child has what is called as cause and effect play. He knows that if he presses the button of the torch, the light will go on. So he is able to connect these two functions. In fact, he's looking up for the fan in my office, which was not there because of being an air-conditioned room. The parent had asked him, where is the fan? He is able to point the torch and look at the light dancing in my room. So this is called as cause and effect play. A similar example may be a child pulling at a string, knowing that the toy would come to him. He is very active, playful, almost fidgety. Now you compare this child's activity, interest, keenness, looking around, and trying to do things like switching on and switching off the torch, with the other child on the opposite side who is hardly moving. I'm showing him an object, a dangling tape, which he doesn't seem to be interested to reach out to and hold. He's looking at the tape, all right, but doesn't make efforts to reach out by moving his hands. Generally, his body movements are less. They lack interest, attention. This child has very high risk of developing global developmental delay. So by 8 to 9 months, the child can sit well. If he does not do so, with a straight back, with good head control, with well spread out, easy to place legs, I must suspect cerebral palsy or local pathology like hips or spine problem. The child should use his index finger and thumb finger together to get a good pincer grasp. Suspect there are problems of vision or any other neurological disorder if you can't do that at 9 months of age. By 9 months, we are evaluating a new domain of development, that is social development. The child should interact and play. He should have joint attention. Absence of these should make you suspect that there is autism spectrum disorders. We mentioned about refraction testing. The RBSK India recommends testing of refraction for all preterm babies by the age of 6 to 9 months. How it is done is classically by a method called retinoscopy, in which light is shown into the eye, and if there is normal power, it would fall exactly on the retina with a good focus. What you would find is an image on, like you see on the left side. If there is a refraction problem, then you would see a different image which moves either along with or in opposite directions in the eye as the object is moved. This would indicate that there is a refractory problem. Then one places a lens to correct this movement of the object and finds out the correct refraction. It is understandable that this process is difficult to execute in small children. Therefore, you may use something called photorefraction or autorefractometer. This is a device recommended by American Academy of Family Physicians for office practice. All you need to do is show the camera to a child who must focus towards you for just a few seconds, maybe 5 seconds or more. And then the camera would capture the refraction, squint, and all other problems for the eye and show you the values. It can be done for children more than 5 months old. Now our infant is 12 months old. Let us see what we expect the infant to do. He should be able to stand momentarily, at least for a few seconds. We can see in this video that there is a baby pushing the chair, stably able to walk with the chair forwards. This is a good stand development. Whereas in the video on the right side, you can see an infant who is much slower, seeking support of the chair all the time, standing on her toes. And this infant is unable to push the chair around. In fact, she has to seek the support of her mother merely to just be able to turn around. And even when a mother helps her to walk, you can see the gait is not stable. So there is a great difference in the development of standing milestone at the age of 12 to 13 months between the two infants. The reason for not being able to stand at 12 months can sometimes be familial. Infants with large head and a relatively small body, which is common in India, may be the only reason for the child not being able to stand independently. Such infants will have no other signs of motor disorder like hypertonia, toe walk, or hand use problems. Of course, this may be the first sign of cerebral palsy. The problems may be in the hips or even in the spine that the child is not able to stand. The other important milestone you would note by 12 months of age is the use of index finger. The child can point at objects with his index finger. He can use his index finger to explore toys. Absence of this milestone should make us again doubt that he cannot see well, refractory problem, or has a global developmental delay, or maybe a cerebral palsy in evolution. The child should now be able to say at least one meaningful word. Also, he should respond to mother's name call. So the mnemonic is half word, that is a babble at 6 months, and one word at 1 year. This is an important language milestone that we should monitor. Some children speak late. This may be a familial trait, so we must always ask family history before we decide that there is a problem. The most important thing to be excluded when there is a language delay is to exclude hearing problems. Of course, global developmental delay and poor social development in autism spectrum disorders may be the cause for delayed language as well as respond to name. So by 12 months, the child should be able to stand independently, at least for a few seconds, use his index finger to point to objects and to explore objects with the index finger, say at least one meaningful word, respond to name call, and have a good cause and effect play like we saw in the video previously. We now sum up the important milestones of the Detect and Treat program. By 2 months of age, the child should have a social smile. So look at the mother, should respond to her call, should smile well, absence of which makes us worried. The child should be able to lift his head in prone and in ventral suspension, but should have no head lag. By 4 months, they keep the hands mostly open, grab an object that is placed in the hands and use the hands well. They would have good head control and try to roll over. The ATNR reflex and the Moro reflex would be gone. By half year at 6 months, they should say half words, babbling. They should be very keen and attentive, reach out and grasp toys, exchange between hands, take to mouth. These are important milestones. By 8 months, the child should sit without support, with a straight back and good head control, and should pivot and play without falling for some time. The knee should not be pulled up and tense. The child would develop stranger anxiety. This may be the first sign of development of cognition and social milestones. By 9 to 10 months, the child plays. He would say tata, mama, and develop joint attention, looking at an object that the mother points to and recognize the name that the mother is giving the object. These signs may be absent in a child who has autism spectrum disorders. Pincer grasp requires the child to pick up a tiny object between the thumb and index finger. This requires motor coordination starting from the brain, may be absent in cerebral palsy and in global developmental delay. This also may be the sign of poor refraction or visual problems. By 1 year, that is 12 months, the child should say one word, respond to name call, and stand without support, at least for a few seconds. Now, all these detect and treat programs are meant to pick up neurodevelopmental disorders. The common ones that present in infancy mostly have feeding problems as common, whether it is cerebral palsy or a global developmental delay. We must also pay attention to correctable factors like refraction, hearing and speech problems, and hips problems. A child who has late motor milestones, persistence of primitive reflexes, high tone and exaggerated reflexes, sits with a rounded back even by 8 months, has his hands fisted most of the time, has a splayed approach to objects, a small head, feeding and swallowing problems, in the presence of risk factors like asphyxia and prematurity, may be actually having evolving cerebral palsy. A child who shows poor interest in surroundings, no social interaction like social smile, joint attention, language delay, and tracks no sound or light, may be a pointer to cognitive problems, global developmental delay. The question is, what can we do to help this baby? Please do not think that it is all dark. Surely there is light at the end of the tunnel. The first thing we need to do is have a team meeting. In the team meeting, of course, the most important person is the family, the pediatrician, and the specialists that we may require based on the listing of morbidities and comorbidities. Is the problem related to hearing? Is it a visual problem? Is it a motor problem? Orthopedic problem? We need to involve all these specialists and clearly define their problem. We need to set goals that this family needs to achieve over the next few weeks and months. One of the commonest problems with infants is that of poor feeding and drooling. A speech and language pathologist can help in achieving these solutions. The other problem we may see is a motor problem, like in cerebral palsy. We have moved beyond mere referral to physiotherapist. The family needs to be told that the child does not have a milestone, like head control or sitting, and we need to plan the therapy so that we can achieve this motor milestone. Give them a goal, as in how many months or weeks we can do this and how we intend to do this. This is called target-oriented motor training. A neurologist may prescribe baclofen for severe hypertonia or may use a botulinum toxin in spastic hypertonias. This infant received 2 shots of botulinum toxin in the calf. This allowed the tone to be reduced for a few months, during which effective occupational therapy without causing pain to the infant was possible. In hemiplegia, we may use a program called constraint-induced movement therapy. In this program, the infant's weaker leg is encouraged to be used by restricting or preferentially offering the games from the side of weakness. In this video, you will be able to see this hemiplegic infant who has been offered an ankle foot orthosis on the left leg. This allows the fixed contractures to be corrected and the child would have a better grade. You see that he has left hemiplegia. Parents have taught him how to improve the hands by doing things like clapping. The child can walk around with a little different but it was not possible without the use of the. You can see his preferential use of the right hand. The speech language pathologist we were discussing can help in many ways. A child who is choking to feeds may be allowed to feed slower by interrupting the feed coming from the bottle, what is called a spacing. They may be able to offer low flow teats because frequent chokings causes discouragement to both the baby and the parents and sometimes failure to gain weight as well. An ophthalmologist may correct refraction, allowing the child to learn from his environment. Squint not corrected in time may result in amblyopia. We may require medications for seizures, for hyperactivity. We may have to address sleep problems, which are very common, causing difficulty not only to the infant, but even to the family when it is a long-standing issue. Co-contraction, that is simultaneous contraction of the opposing muscles of the body, is a common feature in cerebral palsy because of poor inhibition of opposing muscles. This causes constant pain, and we may have to address this in these children. There are many medical issues that need to be paid attention to. Many of the vaccines we deem as optional are very important to cover for all infections. Children who have constipation, reflux, or other nutritional challenges may have to be helped for these. In the worst cases, they may have tracheostomy for airway problem or gastrostomy for severe feeding problem. These children require special care. Skin damage is common because of tone abnormalities and pressure points that these children often have. We cannot forget the parents of this special child. They need to be given clear information on what is the current problem and plan. If they do not know this, they cannot move forward. We need to help them with coping behaviors to understand that even if there is a difficulty, it can be helped. Often parent support groups of children with similar problems make it easy for the parents to ask questions that they cannot get answers for from doctors and nurses. They need psychological support. Entity called secondary retardation involves that if the baby is poorly dull and active, then he does not stimulate the parent. The parent gets bored that the child is not active. In turn, the parent does not again stimulate the baby, resulting in loss of potential. The child may have emotional problems because he wants to play, his mind is active, but his body doesn't follow him. We may have to recognize and address these psychological problems in the child and in the parent. How do I ensure that I do not miss these problems? Remember, in the first session, we discussed about a notebook. We flag the child, list his problems, list the goals, note down the recommendations of specialists, and also follow them up systematically. The pediatrician has to remain the nodal person for the child with special needs. He may take the help of a development therapist or a nurse. Most often we hear from a busy pediatrician that how do I find time for these children? You may have to fix a day of the week or a slot of the day to be able to give more time to these children and families. This is another peculiar problem that these children and pediatricians face. Where can I find these specialists? You may not know all of them at one go, but as you practice, you will refer a child to one specialist or the other. Please note down every time you found a specialist, his contact details, his visiting time, and the hospital where he works. This will help a family who is already strained with a disabled child to coordinate their visits easier. You have to find out an ROP expert, an audiologist, where is BERA done in your city or nearby, EEG, MRI, ortho, especially one with pediatric interest, an occupational therapist, a speech language pathologist. Where is hearing aid being made in your neighborhood? Where can you get genetic advice and metabolic testing done? One more challenge we have in this COVID times is how to call children for development testing. This has been made possible by an innovation that we have found in our unit. We send them the ages and stages questionnaire on the day prior, which is for the age appropriate assessment, and then through half an hour each. At least try to have a list of those conditions which you should never miss because they're very easy to treat and may change the life of a child. Hypothyroidism, hip dislocation, refraction disorders, hearing impairment are completely amenable to therapy. We learned very simple things that can be done in a systematic way. Remember the words 2, 4, 8, and 12. Flag babies who have risk factors with a simple notebook. Offer simple screening programs like thyroids, hearing, ROP, and hip screening throughout infancy. Plot the growth, especially that of head circumference. Record milestones. Social smile at 2 months, head control at 4 months, sitting at 8 months, and standing at 12 months. At all visits, assess vision and hearing. Do a physical examination for medical factors that can be corrected and pointers to cause of developmental delay. Neurological examination has been made easy through simple signs that we demonstrated in these pictures. Please remember, we all can help a child to achieve his full potential. Let us detect developmental deviation and aim to refer early and act timely, that is to treat infants. This program will be successful only if each one of us decides to remember the 4 magic words: 2, 4, 8, and 12. Thank you for your attention.
I think we can stop the video and.
So we came to the end of presentation. So we can, I request Sweta, any question till now from the audience or attendees? So we can address first, otherwise we can initiate a discussion on the.
Checking now.
Till now, no question. So before going to the panelist, may I ask Dr. Radhika? Radhika, available?
Sir, there is a question. It has come in the chat box.
I'd like to take the question there. Does it help if parents are counseled to avoid electronic viewing like TV when teaching a child to interact? Basically, this question is directed for screen time and gadget engagement in the gadget instead of the engaging to the human interaction. So Radhika, please unmute yourself. It's muted.
Hello. Yes. Actually, I didn't hear the question.
The question regarding, typically the question comes about screen timing, and does it help if parents are counseled to avoid electronic viewing? So the question is regarding limiting the screen timing. Is it helpful for the kids to learn better?
That's a very difficult question to answer, because if everybody knows that limiting the screen time, or at least completely avoiding, may not be possible in this era when a lot of devices are resorted to, and even children have online classes. But limiting the amount of screen time will definitely help. But and the parents, I'm sure most parents are aware of it, but there may be a lot of practical difficulties to completely avoid it. So our advice would be definitely, at least in the early initial stages, because we have seen very young infants, even those with having this devices on to feed the babies. And so I think that habit forming can probably, in the early infancy, if we can restrict it and advise the parents, it would go a long way to help in interaction.
Dr. Nalin, I think the question was, since it pertains to only 2, 4, 8, and 12, all the viewers and the participants should note that in this periods, which Dr. Naveen said, 2, 4, 8, and 12, the magic 4 words which we all have to remember, we know electronic gadgets need to be exposed to the infant.
Yeah, but in the infancy, of course,
Can I
below
have
1 year, but
can
will
can I
see
have a
any of the
question?
time?
Can I ask a question?
Yeah, please go ahead, sir.
Which of the important in office practice, which of the important milestones, delayed deployment in milestones indicates for future autism? Which of the milestones we consider which will help us to detect early the autism?
Radhika, should I answer? Shall I answer?
Yes, please.
So the autism is a disorder of a developmental aberration where the communication skill of the specifically interaction with the surrounding or the environment is little bit difficult for the baby. So what the earliest feature we will say, the 6 weeks to 8 weeks, when the baby is social smile we are expecting. If the early detection happens when there is a delay in social smile, if specifically we are seeing social smile delay or the babbling, which should happen by 3 months to 6 months, the babbling, that's not there. Specifically, babbling is absent. And slowly by 9 months age, specifically the more pointer, a specific pointer, when the baby is playing with the parents, the joint attention, when the parents are saying something to do, the baby is doing independently something, but not with the joint attention. We, along with the parents or the siblings, baby is not doing. Because the diagnostic screening starts at 18 months for autism, but these are 3 or 4 specific skills, the communication skills, and specifically social smile at 2 months age, babbling at 3 to 4 months age, and 6 to 9 months age evolution when happens for joint attention. Baby is not socializing and joint attention is not there. So a work baby is not doing together with the sibling or the parents. These are 3 or 4 early markers in the first 1 year, which point out so that by 18 months we can go for the screening and diagnostic. So these are the
Thank you. Excellent talk. Excellent talk.
So any inputs, Dr. Radhika, you want to put any inputs?
Yeah, same, sir. So limited, the eye contact is limited, and the baby is not responding to the name being called, and also pointing to objects, the baby is not responding, and joint attention, as you said, when spending time with the family. So some as early as early infancy, we may be able to have some pointers, but for definitely diagnosing it as autism, we will have to wait to go through the checklist.
And the screen time, I will come back to the question. Dr. Beast actually he pointed specifically to the infancy thing, so absolutely should be not allowed. But the guideline we will extend a little bit up to 18 months when the language skill is maturing. The social interaction when in the phase of maturation, probably up to 18 months if we can avoid the screen time, and limited if exposure, the guidelines say it's below 2 years if somebody is interested to expose different teaching material. At single particular time, it should not exceed more than 30 minutes. And after 2 to 3 years, the cumulative, it should not exceed more than 2 hours in a whole 24 hours after 2 years. So this way we can tell parents some education material interaction they can do beyond 18 months. That's also to limited quantity, not exposing to the large duration of the days. That's the advice. So as Dr. Radhika pointed out, now current age, absolute evidence, is it possible? No, some way we're exposed to TV or different gadgets. So few activities, limited time, and with a gap of a few hours probably might be useful for the parents. But again, I will ask a very pertinent question. Dr. Naveen Jain sir, in the covered this presentation, he covered well in office practice, what are the tools to be used, how to identify. But I will request Dr. Radhika to just to speak about few of the very, very important things when the pediatrician in office practice should not miss it. So by simple examination, he should not miss it some reversible or correctable problems which he can identify in office practice and we can correct for a better outcome. Just highlight 3 or 4 practices. As a pediatrician, we should not miss, even though we are not developmental pediatrician.
Yes. So I think one of the simplest tools that in the office practice, because we will not get time for a detailed evaluation. So by just looking at the developmental observation card, So does the child develop social smile by 2 months, head control by 4 months, be able to sit alone by 8 months, can stand alone by 12 months, and the baby can see, hear, and listen. So this is something we can easily pick up. So the earliest thing would be vision, because we have had babies who because of the lack of social smile, and when we did a vision examination, the only reason the baby's social smile was delayed was because the baby was not seeing properly. As soon as that was rectified and the baby was prescribed glasses, there was a rapid change in the response of the baby started smiling, recognizing the mother. So maybe at 2 to 3 months, maybe that problem was not attended to or recognized. So early detection of these deviations from normal, and if you act timely and in that time, it may go a long way in changing the course of the baby. So at least find out things that can be corrected, or if there is a hip in the problem in the gait, maybe because the hip examination is abnormal and we have not done a proper hip evaluation, that is why the child is having an abnormal gait or a walk. So that these are things that you can recognize the red flags.
So to summarize, head circumference, thyroid, hearing, and vision, and to add an hip examination, if we will do correct, probably those things can be better corrected the outcomes.
Yeah.
I will just, may I request Dr. Arjit sir or Dr. Rajesh sir, if both of them are available here. May I get Arjit sir or Rajesh sir? Because my question initially, or I will change to Dr. Beast sir. Actually, आपको just if one question I will request to highlight, if we want to do the developmental screening for at-risk babies, in particular a government sector, what challenges you are seeing actually, how it's not achievable? Please tell us actually government sector how to optimize.
So since I'm working in a government hospital, that too a municipal hospital, and the challenge is about feeling that we need to do it. That is a lack of awareness, which is there among all level of practitioners. My wife is a practitioner. She is a pediatrician working in a private setup. I'm working in a government setup. Thing is, nobody pays for it. And in government, nobody actually, there's no reward to do it except the personal motivation. The families are not that aware. And you are not responsible for actually, you are responsible for actually bringing down the fever, taking care of the diarrhea. These are things which they want you to respond to. नहीं बोल रहा, नहीं चल रहा, ठीक है, चल जाएगा, हो जाएगा बाद में, अगले बार ले आना, अगले इंजेक्शन में ले आना. And sometimes after the third vaccination of 3.5 months, they are not seen. So the 6-month visit or a 9-month visit then is the only thing which is left. And by the time the early markers of CP, which Dr. Naveen had already shown at 2 months, 4 months are missed. So you have even the 8th month is also missed. So it is a little delayed and early intervention is delayed. So for those aspects only, RBSK has designed a district early intervention center across the country, and many district, almost 90 to 100 have been opened up in all the districts hospital. And fortunately in my hospital also, we are also going to start a district early intervention center where we'll have the services of physiotherapists, occupational therapists, speech therapists, language therapists, and optometrists, audiologists. All those will be available, but it's a busy kind of and very kind of a you can say resource intensive setups, and which requires a lot of funding also. But for general practitioners, general pediatricians in all setups, whether public or private, they need to look at this 2, 4, 8, and 12, and then they can refer it to DICs in public sector, and they can refer to a developmental pediatrician in private sector also.
Thank you, sir, for opinions. So I to extend the question, I will ask Dr. Radhika, who is heading a neonatal unit in a government sector, SAT Trivandrum. So they're actually at-risk babies, you are dealing at-risk babies. How are you optimizing their follow-up? The challenges we know.
Yes,
government sector challenges no, but few things you tell from your experience, few things, how can optimize the follow-up in the government sector specifically?
So it is really a challenge. As sir said, in the busy practice, incentives are not there. The OPD is very busy and we are dealing with a huge number of babies. So we may not be able to do a justice or a full developmental assessment to address all the answers at once. So one thing that we do is we do a risk stratification at the time of discharge. So we will stratify at least the babies who are admitted in our NICU. We stratify them into low risk, medium risk and high risk. So the high risk ones would automatically go into an early stimulation and early follow-up. And we are very lucky to have the Child Development Center, which was set up by MKC sir just across the road. So in that way, our job is easy. So whichever babies are high risk, we can just refer them there, because many times we don't have time to spend with the babies, and in a busy practice doing a detailed developmental evaluation. But at least if we can identify the red flags and guide the parents timely at early stage, then maybe so we will be able to address this, and we may not be able to give the same attention to all the babies, because so that is why we do this risk stratification, and the low risk babies have less, all of them do need follow up, but we divide the level of follow up according to the risk category.
So perfectly fine. So categorization, triaging in the any sense, we know there are many emergencies, how to triaging, use the resource in best sense. So this way also, by categorizing the risk, probably we can highlight who needs best, who needs early. So that way we can direct all the resource. So Dr.
So can I have a comment on?
Yeah, please go ahead.
May I have a comment?
Please go ahead, sir.
In our day-to-day practice, we are always seen that the gynecologist and obstetrician delivering the baby in cesarean section or in normal delivery. The birth section started from there. So to minimize this, they are hurriedly doing in normal delivery. They are pressing the uterus to deliver the baby in a very easier way. So if we can curtail this point, the asphyxiated point from the very time of delivery, then we can also reduce or minimize this future delayed development or
Please unmute yourself, sir. And one of the probably two devices you have logged in, one have to actually log out, because there is two devices that is showing. Please unmute yourself, sir. Please unmute yourself. So your points well taken, sir.
Can you hear me?
Yeah, now perfectly. We can hear you, sir. Your points already, we heard your points, but it was a little two devices it was showing. So I just requested you to log out from one, sir. We heard actually the points well taken, sir. You are highlighting the right point. In a good antenatal care, good perinatal care, and a good perinatal team always ensures a good quality. Whenever there is improper care or the quality issues comes, so that leads into this type of a different form of injuries in the brain in the early phase, which we are seeing later. The results only we are seeing later. So optimizing premature care, optimizing small babies care, optimizing the care at the delivery room, definitely going to help us. But that's not probably specific in the developmental follow-up field, but that involves the responsibility of perinatal team. Both obstetricians and neonatologists or pediatricians who are attending, they should optimize the care at the beginning, so we will see the better outcome definitely. There's a point rightly pointed out, sir. So specifically, I will, if Dr. Rajesh or Dr. Arjit sir, anybody is available, because they're huge experience in the private sector, almost a 15 years to 20 years experience, I will just request them to highlight what the challenges of getting this development screening program in the OPDs in the private sectors. Any of them, if available, actually, you can ask her. Dr. Jyoti Prakash, sir, you can also speak actually private sector. What are the real challenges? So you can address few.
Yeah, actually, Actually, Dr. Panigrahi, I am unable to on my video. You can just adjust me. My I'm just talking from my voice because I am unable to because I'm traveling. So just I'll tell that I'm just correcting you. I'm not from the private sector. Actually, I'm a government sector.
Yeah, I know. Just as they're not available, I'm requesting.
Yeah. Yeah. Okay. Early developmental screening actually we are doing in government setup. That is, we are actually having a high risk follow-up clinic in Capital Hospital. There actually we are two people, Dr. Pradhan and myself. We are doing the screening every Friday. We are calling those people. So that is going on. And again, we have also district early intervention center. That is running for last I think it is 10 years. It is running from 10 years. There also we are able to detect, but the problem is that many high risk follow-up cases, even if we remind them by our data entry operator, still they regularly they don't turn up. And there are some tests for which actually we have to depend upon the AIMS Bhubaneswar and some specialized tests. And those tests are these poor people are there, so they cannot afford. So you have to depend upon the government setup. And the third thing is that when they go to the periphery, these are the people who are nearby people from Bhubaneswar. But in the peripheries, other districts, it is very difficult to track them and to do a regular follow-up in all the SNCUs. So that thing is missing. We have improvement in all the SNCUs so that at least this minimum follow-up at the two and this 4 months and your 8 months and 12 months, this can be done. And at least the frontline workers like ASHA and we have got a new system in Odisha, that is the community health officers. So those people are staying in the village sub-center. So if you can have some this type of teaching in local language, placard type things, then these people are going every 15 days. They are having VHSND days, village health and nutrition days. In that day, they can call the mother and newborns, their screening, and they can also be trained in the local language, very simple language, how to detect early and send it to the nearest DEIC.
Thank you, sir.
So that is my observation. This is my recommendation also.
Yeah, perfectly fine. Involving the government sector, the facilities, the developmental screening program in district level. But I am from a private sector. To highlight the things, I will share my experience in the last 12 years, what we did. So initially, when to start with, and we saw that the follow programs we see in India everywhere, even the published papers of developmental follow, we see the accretion rate is very high. Follow-up only happens to 15 to 20% babies which discharge from the NICU. So when we saw the same problem when we audited, we saw that only 20% are coming to the clinic if we are asking. So few initiative we started, we successfully implemented later. So what we did normally before discharge, when we get the discharge summary, a specific session or counseling was there, need of their developmental screening or developmental follow-up later. And the last page of the discharge summary, we included a calendar up to 2 years, 4 months, 8 months, 12 months, 18 months and 24 months. These are few visits in the calendar and dates. From the birth date, calculated the dates, we have written in discharge summary. We have written and given to them. But at least we made them aware. If there is a need of developmental follow-up, they have to come back because of the risk identification started. With the counseling, giving a schedule to them, and later keeping their number, one of the parents' number, mobile number, and messaging. Because of private sector, we could afford to message them at least a regular interval 4, 8, 12 months in our personal capacity. So with that, the increase follow-up started, and we reached almost, we can say 75 to 80% of high-risk babies who are not now able to do the follow-up. And again, the problem happened in the COVID era. COVID era, people due to travel issue, they could not come. So we implemented, as Dr. Naveen Jain sir also highlighted, we were initially screening with the development Denver screening and definitive test like Dasi or Bailey we were implementing, but we changed to screening method to ASQ, parental questionnaire. So questions we provided to the parents and they just tick the answers, 30 questions, they tick the answers, sent back to us. So we screened without sometimes their visit to the hospital. That ensured few of the regularity in the follow. So depending on the area where we stay, what are the challenges in that particular area, in that facilities, our problem, we can sort it out in many ways. So by keeping their number, sending message, giving a calendar, few of the small things we can do. And when they come back to us, instead of asking them to visit many of the centers for hearing one place, for vision one place, weekly one clinic we can do in single facilities where all can visit and you can gather babies, probably that can be more successful. And if that's not possible, keeping their numbers and guiding them, sharing with the parents, the specialist number like physiotherapist, occupational therapist, speech therapist, or the neurologist, or the ROP specialist or hearing, keeping their number and providing to the parents can help them to go to, and when they come to the city, same city, they can go to different people in the same day, they can finish their developmental screening along with all other morbidity screening they can do. So few of the steps can be done in private, better can be done in government sector because available facilities in areas and the floor available always, but a few facilities in government sector when it is not there, involving the district level developmental institution, we can probably do a better screening methods. So with this, actually, I will invite Dr. Beast or Dr. Anup any few final words to, I'll invite them to say the final words, then we can probably close the session because we don't have much questions here. So Dr. Radhika, Dr. Anup and Dr. Beast, I'm inviting to say a few words. After that, we can close the session for today.
Excellent talk, excellent discussion, and excellent participation, excellent interaction. The words I can say, and I want this type of programs should be implemented in everywhere we can get a chance, so that the pediatrician, common pediatrician will learn so many things and they can implement it. Only a few persons like us cannot discuss and cannot implement all these hazards or all these which the DETECT program will say. So we have to arrange such type of programs in every conference or every it's a part of the every conference, so that we can give a trace to the program. And I am very much thankful to all the organizing persons of this DETECT program, particularly you, Dr. Noveen and Dr. Bisi, and also my heartiest thanks to Dr. Pejwar, who has initiated this program. Thank you, everybody, for nice participation and nice interaction. Thank you all.
Thank you, sir. So one request to Dr. Beast, sir, for NNFI national level, because we did a DETECT program, probably the plan must be going on, but if we involve DETECT with the nursing DETECT, so the nurse will be trained for this DETECT, probably it can be more far reach, and the result can be better.
Is it little different from that, or is it almost same?
DETECT we can shorten probably, but can we do a program for just nursing staff? That's why I'm just asking. Can we involve the NNFI? Can involve the nursing program?
So we should certainly look into this, and as Dr. Jyoti Prakash has said, because it is for ASHA, then even for village health and nutrition days also, where people can detect. In fact, for the Ayurvedic people who are in RBSKs who can detect early, so a program should be made for them as well. So I hope as part of responsible NNF functionaries, all of us should make a program so that more babies can be detected at all levels.
Thank you. Thank you very much for your support throughout the program. Thank you very much.
My also one suggestion, can I have a suggestion? Hello. I also give a suggestion in this context. We are holding the breastfeeding week. We are holding the neonatal week. Like this, can we, just a new program. And if we implement this program widespread in all the health staffs, then it will be helpful for us to detect early and to treat early.
That's a good suggestion. That's a good suggestion.
Dr. Radhika.
Thank you. Thank you all for your patient listening. The DETECT program has been going in the online mode successfully for more than a year now, and it has been accepted well. And I think, as you said, the grassroots level, because sometimes there are many places when the patients do not come back for follow-up. And so even educating those who are working in well baby clinics, in immunization clinics, paramedical staff, and the ASHA workers will go a long way for early detection, because sometimes many of the times when they reach the medical doctors or reach us, it may be a little bit late. So if you want to detect early deviation from normal, involving these other paramedical staff also would really help in improving the developmental outcome of these babies. So I think the suggestion should be taken well, and thank you, sir, for putting forward. And I think this kind of a extended detect program for other health workers will also be very useful. Thank you.
So thank you all for nice participation. Before closing, I should thank at least Dr. MKC, Professor MKC Nair, who probably started this developmental screening and developmental program very early, and Dr. Naveen Jain sir for this program, from which we learned a lot, probably the mutual learning experience and program. And I again, before closing, thank all the panelists and participants for your inputs. And with that, we are closing the session today. And thank you. Bye-bye.
Bye. Thank you, Dr. This moderation and all the faculties, especially ma'am and our sir, Anup sir, and our Naveen sir and Rajesh sir, Arjit, my younger brother. So I'm really excited and I learn a lot from the this platform. So thank you all. Wish to meet again in a short time. Thank you all.
Thank you. Bye-bye.